and shoulder health is vital for everyday functionalities. Pain can arise from a variety of causes, which can significantly impact daily life. Reach out. Insights into hand and shoulder wellness. Tonight, on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. I'm Dr. Andrew Ellsworth, your volunteer Prairie Doc for this evening's program. Tonight we are discussing hand, wrist, elbow, and shoulder injuries and answering your questions throughout the show. Hand and shoulder issues are common musculoskeletal problems. From repetitive strain injuries like carpal tunnel syndrome and tendinitis to shoulder impingement and rotator cuff injuries, these conditions can significantly impact your daily activities and overall quality of life. In the studio this evening are Dr. Yorell Manon-Matos from Avera Orthopedics in Sioux Falls and Brookings, and Dr. Tony Fiegen from Orthopedic Institute. Thank you both for being with us here tonight. Dr. Manon, could you please share a little bit about yourself and your background?
Yes, well, I was born in Puerto Rico. I grew up outside Philadelphia, and I moved to South Dakota after growing up out east. That's where I did my training. Did my undergrad at Princeton, my med school at Dartmouth, my residency at Tufts, and I did my fellowship training at the University of Louisville in Kentucky. And then I moved here in 2010. I was previously in practice in Dakota Dunes, and I've been with Avera over the last couple of years. Yeah.
So you're newer to the Sioux Falls and Brookings area, but you're well familiar with South Dakota, and you knew what you were getting into.
Yes.
You must like it around here.
I like South Dakota. It really, it's a good fit for me, and I love the state. I love the values and the people, and it's a good match for me.
We love having you, and he comes from Sioux Falls on outreach and shares the hallway with me most Wednesdays, and so it's a pleasure working with you.
Every week.
Yeah. So share with what you do in your practice.
Yeah, so we treat all ages from 6 months to 106. Okay, from all aspects of hand surgery, whether it's injury or degenerative problems such as nerve problems or tendon problems, fractures. A lot of arthritis, anything that has to do elbow to fingertip. It's what we treat. Yeah.
And so if you need to get beyond on the elbow, then we might go the shoulder and we might see Dr. Fiegen here. Tony, tell us a little bit about yourself.
Yeah, thanks for having me back. I'm originally from Madison, South Dakota, just down the road. I spent 4 years here at South Dakota State, loved my time here in Brookings. After undergrad, I did my medical school at the University of South Dakota, Vermilion. For 4 years, and then I transitioned to the Mayo Clinic where I did my orthopedic surgery residency that lasted 5 years, and then did an additional year of training at Wake Forest University in North Carolina in sports fellowship in sports-specific surgery prior to coming back to Sioux Falls last fall. So we've been here now in practice for just over a year. My family, my immediate family, my extended family is all from here, so it's really fun to be back.
Well, it's great having you back too, and as a fellow hometown Madison person, and then in the Brookings connection and everything, it's great to have you back on campus here. And I don't have any basketballs around, but you're an expert in orthopedics and shoulders. And what else do you mainly work on? Shoulders and knees and hips, I think, right?
Yep. Arthritis, joint preservation surgery, non-operative treatment of the shoulder, hip, and elbow. Sorry, shoulder, hip, and knee.
Right. Excellent. Well, prior to diving into our conversation, I want to take a moment to acknowledge and thank all of our viewers. As a volunteer Prairie Doc, your support is incredibly important each week. Every dollar you contribute plays a vital role in helping us create impactful content that enables individuals to make educated health choices. Thank you. Now let's turn our focus to you, our audience. We invite you to submit questions for tonight's conversation on hand, wrist, elbow, and shoulder issues. There are 3 ways to reach us. Call us at 1-888-376-6225, send an email to ask@prairiedoc.org, or engage us on our Prairie Doc Facebook page. We will do our best to address as many of your questions as time allows. If we can't get to yours, we sincerely apologize. All of your questions are anonymous, and no information will be saved. However, if you would like to leave your name, email, or phone number, you'll be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie. It's not a requirement to submit a question, however. We'll announce the winner at the end of the program. So we've already got several questions from emails and Facebook, and the first one on my list here has to do with the shoulder. This person says, I've been having shoulder pain, and when I rotate my shoulder around, it makes a popping sound. It's not all the time. What could be causing the popping sound? And then they say a friend suggests maybe frozen shoulder, and what is that? Well, first, what do you think of when you hear this popping sound?
Yeah, the shoulder is an interesting joint. Of all the joints in our body, it's actually the one with the most mobility. So it relies heavily on the soft tissue stabilizers about the shoulder. The rotator cuff is one that probably most are familiar with. There's also a structure called the labrum in the shoulder. As far as what can be causing clicking, popping, mechanical type symptoms that are described in the question, it could be early arthritis. It could be soft tissue pathology. My question, if I was able to ask the patient who wrote in, is if it's painful. If it's not painful, our joints can make clicking sounds and it can be benign and normal. Frozen shoulder is a condition that usually leads to stiffness. If there's a significant loss of motion, both active or the patient trying to move their shoulder themselves, and with a clinician also experiencing stiffness when they're trying to move the shoulder for them, that'd be consistent with adhesive capsulitis.
Yeah, so frozen shoulder, adhesive capsulitis, one of the common things that can contribute and cause it is diabetes. Mm-hmm. And so getting your diabetes under control is important for that. What do you do it's frozen, it hardly wants to move, it hurts to move. What do you do there if it's frozen shoulder? Yeah,
out of the gate, the standard of care is a good referral to a physical therapist. That's the standard of care treatment. It's an inflammatory condition in general. The capsule usually becomes inflamed for reasons that sometimes we don't know, but as you mentioned, patients with endocrinopathies, diabetes, thyroid disorders, they're more prone to it. Sometimes an injection into the joint can help decrease the inflammation, soften up the capsule, if you will. We try really hard not to do surgery on adhesive capsulitis. By definition, it is a self-limiting condition, or in most cases gets better on its own without surgery. But that's not to say that it doesn't require treatment. Again, most times it's successfully treated without surgery.
Excellent, excellent. Well, when I think about clicking, I mean people click their hands a lot too. Is that a problem?
No, I mean he brings up a good point that joints click and clunk, and as long as it's not painful, or if there's no injury associated with it, or let's say arthritis, it's quite common, especially in the wrist. Yeah.
It made me think of though too, when people crack their knuckles.
Yeah.
Are they causing damage? Is that a bad idea, or is it okay?
In theory, no. I guess no one really knows. In theory, it's probably it doesn't cause any harm, but it's probably not a good thing to do.
Okay.
I mean, I think I do it occasionally. Yeah. I think we all do a little bit. Yeah. Yeah.
Whether we want to or not, it's going to happen right. I'm sure. This person says, when I sleep at night, my arm goes to sleep, and there is sometimes pain in the morning. What can I do as a side sleeper to not have my arm and hand tingle in the morning? What do you think of when you hear that question, Yorell?
A numb and tingly hand or arm can be a lot of things. I think more commonly we think about nerve irritation and compression, but we always want to look at the entire extremity and the entire system. So we want to look at the cervical spine, make sure there's not a problem there, maybe an old shoulder problem. I'll defer to my colleague here. But more often than not, it's at the wrist level, which is when you think of carpal tunnel syndrome, or at the elbow. And quite often we sleep with our elbows flexed and our wrists flexed like this, and that can bring it on. And that really points to either the elbow or the wrist. And if it's at the elbow, that's when you think of ulnar nerve problems or cubital tunnel syndrome, and that's when you think of maybe a numb small finger or pinky. And the other fingers, if they go numb, then that's when you think of carpal tunnel. But again, you got to look at the entire extremity.
Yeah. And so, carpal tunnel, that median nerve is getting pinched at the wrist,
That's right.
And it's affecting mainly the thumb and those two, the pointer finger and the middle finger.
Correct. Yeah.
Numbness, tingling. What's the first line treatment for that?
The first line treatment is often just a brace that you use at nighttime. And if it's a numb pinky, maybe a brace for your elbow to try to keep it extended. I would say half the patients tolerate it. Usually they might take it off during sleep. And then that's when you start to look at other things. Maybe if they can tolerate it, a short course of steroids or anti-inflammatories, maybe a cortisone injection, and then you go from there.
Yeah, you know, along the same lines, there was someone that was asking about, they have a job that requires a lot of repetitive motion, and at the end of the day, their hands hurt. Mm-hmm. What can I do to prevent the pain every day? They said most of the time Tylenol takes care of the pain, but it's been happening more lately. What do you think of there?
You know, that's a tough one because, you know, you have to work, and you can't automatically change your work duties, but especially it depends on their age. That's when you might start to look at arthritis-related problems, especially at the end of a busy workday. Some folks especially if they're younger, you might even see some cramping, some nonspecific pains, or carpal tunnel syndrome in some cases, or even dystonia in some cases. But more often than not, for a working patient who really uses their hands all day, you're looking into arthritis-related issues. And that's tricky because there's no good silver bullet for arthritis. You really have to take it almost on a joint-by-joint basis. Yeah.
So one of the most common complaints I see when it starts to be arthritis in the hand is pain at the bottom of the thumb.
Yes.
And why is that anyway?
You know, anytime you pinch that's one of the most common joints affected is right here at the base of the thumb. Because anytime you pinch or grip, you transmit force through that joint. And that's what we call the thumb basilar joint or the thumb CMC joint. And there are lots of treatment options for that, but we all start getting a little bit of wear and tear in that joint, even in our 30s. Women more commonly than men for reasons that aren't entirely well understood. But there are lots of treatment options, and we often start with a brace, anti-inflammatories, and again, maybe a cortisone injection. And there are a whole host of surgical options for this. But it is one of the most common joints affected.
Do some of those creams, are they helpful? Are they a good idea or not?
I think so. I mean, there's some have a placebo effect, and others are really truly effective. I think the anti-inflammatory creams work really well, and then you're seeing more and more some experimental studies for things like CBD and those, and we don't really have any good information on those.
Yeah. Coming down the pike yet.
Yeah, that's coming down the pike. Yeah.
You know, going back to the question about they're laying on their side, you know, because I get that a lot of people complain about their shoulder pain and having to lay on it, and that's when it hurts at night. What makes you think of, when you hear that, what do you think of?
Common things being common, the rotator cuff, if there's a problem with the rotator cuff, it's actually quite common. Patients will come in and tell us that they have pain at night. Some patients even resort to sleeping upright in a chair because the shoulder feels better. The rotator cuff, when functioning well, if you think of the shoulder, the socket side like a golf tee and a ball, that's how I best describe to patients what the shoulder joint looks like. And the rotator cuff serves to hold the ball concentrically perfect within the socket. And when not functioning properly, there could be some micro motion associated with that. Just the additional soft tissue stabilizers, if the rotator cuff isn't functioning properly, can get stressed. And for reasons perhaps not well understood, patients tell us that they sometimes have pain at night if they have a rotator cuff problem.
And what do you do then?
It depends. I think if the rotator cuff problem is identified, it's important to hear a history. Was it a traumatic event that caused the rotator cuff problem, or was it just associated with aging? We're more prone to recommending surgery in the setting of traumatic rotator cuff injuries. There's been a pretty good study that was a prospective study that one of my partners was involved in enrolling patients, and those rotator cuff tears that develop as an aging process, which is actually very common, we're able to help those patients 70% or more of the time with just some physical therapy. Now, certain patients don't get better with physical therapy if they have rotator cuff problems, and that's when we consider surgery.
Sometimes I got patients that really want an MRI and they want to see if it's the rotator cuff, but from what I understand, we could do an MRI on most older patients and it would probably show some damage to the rotator cuff. Have you seen that?
Yeah, it's definitely it's a structure that sees the age of the patient. We get rotator cuff, we get shoulder MRIs, and the rotator cuff very rarely looks perfect, as it did perhaps when we were in our teenage years. And so the history is very important, whether or not there's an injury or not. If there's not an injury, I almost always recommend physical therapy early on, and with initial failure of conservative treatment, meaning ongoing symptoms, that's when I'll consider an MRI for our patients.
Sounds good. Thank you. Well, relief from nerve pain and discomfort is now more, just a second, is now more accessible, offering patients a wider array of options for finding relief. Prairie Doc recently discussed an endoscopic, minimally invasive procedure for carpal tunnel syndrome with Avera.
Working 37 years as an electrician, Greg Horn knows how vital his hands are to his work.
It's not even just job, just everything in life, just to do. Yeah, that's what makes your living is the hands, I guess.
But for the last decade, there's been a little more electrical tingling on the job. And we're not talking about the wires.
So Greg came in, as a lot of patients do, with numbness and tingling in the hand.
Just like your hand falls asleep or whatever, tingling in your fingers and that kind of stuff.
We diagnosed him based on exam, and also we get a nerve study that shows that he did have carpal tunnel syndrome. And so we talked about the options of treatment.
They did mention a shot, and that would only be last for so long and so many times.
And so we talked about surgery.
Patients now have a broader selection of choice for their surgical repair. There's the traditional surgery, a wide-awake option in the clinic, or a third minimally invasive procedure.
One of the options we have is an endoscopic approach, and that's what I prefer. And the nice thing about that is, instead of, the carpal tunnel really goes from the palm here, really up to the wrist area. And so back in the day when we started doing these, before my time, we used to have big incisions that would go all along the wrist. Patients would need a long time to recover, and they would even be immobilized in some cases, so you get stiff and things like that. Now we can do it endoscopic, which again is my preferred technique, where you have a small incision here at the wrist, and through that, with a special instrument and a camera, we can actually release all the way down and all the way up here. So we'll release that same entire area of the carpal tunnel that's putting pressure on the nerve, but we can do it through that small incision. The nice thing about that is, smaller incision, less pain, quicker recovery. I've had patients who are generally very happy with that approach.
One of those patients is Greg, who is wishing he would have listened to his body a little sooner.
I wouldn't put it off too long. I work with a lot of different guys that have had the issues over the years, and it seems like the sooner you catch it, the better those people have return. I would say as soon as you think you have it, start seeing somebody about it. So.
In terms of surgical care for carpal tunnel pain, there's no right or wrong choice. It's just another tool for surgeons to tailor care around each patient.
Depending on the exact pathology and whether they've had previous surgery and kind of their expectations and what they'd like to get back to, we do tailor it quite a bit. So I think it's just, it becomes, after the general points, it really becomes a discussion with each individual.
With a smaller scar on the wrist, rather than the palm, Greg is ready to get back fully to life, just 2 weeks after surgery.
Good, very good. Yep, everything's, I know, no sleepless nights and stuff, so it worked out good.
Yeah, really interesting what they can do for carpal tunnel surgery now. What are some of the other different types of carpal tunnel surgery, Yorell?
Yeah, so the main concept of carpal tunnel surgery is just to decompress or divide the tissues around the nerve that pinch the nerve. So the good thing for patients is that it doesn't matter if your surgeon does an open approach or an endoscopic or a minimally invasive approach, the outcomes are the same. Okay. Now the healing process sometimes is a little trickier. So if you do an open incision, which is just an incision in the palm, the outcome is the same as whether you do a minimally invasive, which is just a small incision, usually in the wrist with a camera or scope. Okay. And why might that be more challenging? An open incision involves healing of the skin structures. Less of that healing with endoscopic. That's probably the most common, but there's a whole host of other ultrasound-guided minimally invasive techniques, some where you use an endoscope, as you might have just seen, and then the conventional open approach.
Yeah. So if you have carpal tunnel and you're thinking about surgery, worth a discussion with your surgeon, I suppose.
Yes.
We've got a lot of great questions coming in here. This person says from Yankton that they had a high-impact fall a little over a year ago in the separated left shoulder, experiencing pain radiating to the elbow, and was told there's no surgical options. The caller's wondering what can be done. So what's a separated shoulder?
Separated shoulder is kind of a generalized term to describe an AC joint separation, or where your collarbone meets your shoulder blade. The A is the acromion, or a projection off the scapula of the shoulder blade. The C and AC joint separation is the clavicle. It's a pretty painful injury, as I'm sure this patient could attest to. Early on, we try and put these patients in a sling. Certain characteristics do warrant consideration for early surgical stabilization. Most of the times, if patients are having difficulty, we end up doing what's called a reconstruction of the AC joint. We basically anatomically reduce the clavicle back to its neighbor, which is the acromion. And many times we're reinforcing that with a graft. Again, if patients are unable to maintain their activities, if they're unable to do things they like to do with other measures outside of surgery.
Now this person was having pain down to their elbow, and maybe it was a different injury with the same accident. What do you think might be going on there?
Yeah, hard to say. It could be just radiating pain. Many times patients with shoulder problems will tell us that they have some radiating pain, often not all the way to the elbow, but it's not uncommon to have radiating pain down the lateral aspect of the arm.
Gotcha. So worth maybe another discussion. And do you think physical therapy could be helpful too?
Yeah,
or?
physical therapy is helpful for getting range of motion and some strength back. Our therapists are great. The shoulder is very complex. A lot of our shoulder movement is the shoulder joint itself, but our scapula, or shoulder blade, also pivots on our chest wall posteriorly. So our therapists are excellent at looking at shoulder mechanics, movement, and making adjustments.
Excellent. Might be going back to carpal tunnel here. This caller from Sioux Falls says about 2 to 4 years ago they fell off their bike, went to the ER, and the patient now up with hand and arm numbness and was told it was carpal tunnel, but the patient was wondering if a pinched nerve could be cause of the numbness.
Yeah, so that's an interesting one because numbness in the hand after an injury can be attributable to lots of different things. Sometimes you can have carpal tunnel syndrome or any other nerve pinched in your throughout your neck to the hand that now has been flared up or exacerbated by the fall. Other times you can fall and actually bruise the nerve and have what's called a neuropraxia, and now you can develop a carpal tunnel type syndrome. Other times the injury can be so bad that it actually causes in an acute setting nerve compression or irritation, and that's in an acute setting. So that really would warrant evaluation of what was really the mechanism, what happened, what's the timeline. But it's worth a workup to look at, again, the entire system from neck to fingertip.
And so now they can do a nerve conduction study to help determine how the nerves are and sometimes where they're pinched. Tell us about that and how that helps.
Yeah, I find those studies extremely helpful to give me an idea of how the nerve is functioning and working at different levels, and if there is nerve irritation, to what extent, how severe it is. It's not an absolute requirement in making the decision or making a diagnosis or treatment, but it certainly provides a lot of useful information.
This person says their son is 12 and has been complaining about shoulder hurting. He has not fallen and has no bruising. He is active. Can you have growing pains in your shoulders? So 12-year-old.
Yeah, you certainly can have growing pains. If the patient's a year-round athlete, it could be overuse. It could be a multitude of things. Many times, x-rays are helpful if it's a true overuse injury. We can see changes that are subtle but are based at the growth plate, abnormal separation of a portion of a growth plate. It's actually pretty common in our overhead throwers, baseball players, pitchers, primarily overuse injuries, but it certainly could be chalked up to growing pains.
So reasonable seeing someone about it and seeing if we need to back off or?
Yeah, absolutely.
Yeah. Sounds good. This caller says they're diagnosed with radial nerve palsy and asking about treatment. We're talking back to the nerves again.
Back to the nerves. So, that's a very tricky one because the radial nerve palsy can mean a nerve anywhere along the path of a nerve from its origin at the cervical spine to the brachial plexus to the upper arm by the humerus, even at the forearm. So very important to do a proper exam, really understand the injury mechanism, what radial nerve palsy means. And it's not always an injury. You can have some rheumatoid arthritis or even tumors are associated with it. You really have to understand the mechanism. But it can be a complicated problem. yeah. And so often we start with treatment with just therapy for these folks to try to stimulate the nerve. There are surgical options, but it can get pretty complex pretty quickly.
Yeah. This person says they took an archery class this summer, and the next morning their fingers were numb. Most of the feeling has returned, but the tip of the middle finger still feels off. They ask, am I doomed? So that tip of that middle finger is still numb.
You can still use a crossbow. No,
Yeah.
no. I think that's a tough one because it could be again, which hand was it and how were you holding it? I would say that's that type of focal problem. It'd probably give some time to see if it can resolve on its own.
It's amazing how nerves can regenerate and
yeah, there is a regrowth factor and recovery issue there. That's true. Yeah.
This person says from an email, my son broke his clavicle playing football last season and sometimes it's still sore. What can he do to make it feel better after practices?
Good question. First question would be whether or not this was treated surgically. If it was treated surgically, sometimes our implants, especially in our young teenage population, the implants are proud. It's a discussion I have with my patients. If we fix your clavicle fracture, everybody can touch their collarbone. It's subcutaneous in nature, and so there's a chance up to 30% of the time we have to do a secondary surgery to take implants out. If it was treated non-operatively, there's obviously no hardware there. It could be, going back to a change in shoulder mechanics that's amenable to some physical therapy. It could be ongoing remodeling of the fracture. However, how long ago was the fracture?
It looks like last season.
Yeah.
So yeah.
So the fracture is likely completely remodeled, hopefully healed. If there hasn't been any follow-up x-rays to ensure radiographic healing, that could be an important consideration.
Very good. This person from Sioux Falls asked, they broke both elbows at the same time 3 years ago. Wondering what's the timeline for regaining strength as the call reports not having much strength in the hands even after 3 years now. So they broke both elbows. And those hands are still pretty weak, it sounds like.
That's a difficult injury. Definitely the type of injury where we collaborate with our partners on. Again, it depends on the type of fracture, the type of injury. Sometimes you can have associated nerve injuries with this, but we also have to figure out what they mean because elbows get stiff, and then that can really impact your range of motion, your strength and recovery. So. That again, I would recommend getting a formal evaluation for that, and sometimes you have to have a very realistic discussion as to how much function will actually return after significant elbow injuries.
Right, right. And I think maybe it's a reminder of the importance of early physical therapy after an injury.
Yes.
Because it can be tempting to broke something and it hurts a little bit and you don't want to move it. Yeah. And I'm sure you see this in any joint. Mm-hmm. We've got to try to get them moving again. I know when you come visit us in Brookings, we've got the physical therapist right there with you, right, seeing every single patient, because why?
Yeah, I mean, we're lucky because we have the hand therapist in our clinic, and because, especially for hands, early active motion is critical. So therapy is really half the battle. I can do an amazing operation, but I'm not going to get a good result without good therapy.
Yeah. But on the flip side, I think of a shoulder surgery and you putting someone in a sling for 6 weeks without moving it, boy, how do they get their motion back? I mean, obviously therapy, but.
Yeah, I tell each and every one of my patients that if we repair your rotator cuff, stiffness post-operatively during the healing phase is an expectation. Hopefully that helps with a little bit of the mental aspect of the recovery, but certainly to your point, to Yorell's point, I mean, without a good physical therapy routine with a good treating physical therapist, many of our surgical outcomes would be far inferior to those where we're able to collaborate with our therapists.
This person from Facebook says, the muscles in my neck and shoulder are always tight from probably sitting all day at the desk, and sometimes this causes pain from my shoulder to my elbow. What can I do about this?
That's kind of a complex question. It could be shoulder itself, and going back to kind of the shoulder mechanics, it could be just the stress of the surrounding shoulder stabilizers compensating for other structures that aren't functioning properly or injured. It could also be an organic cervical spine type of presentation. All the nerves that innervate our upper extremities, our shoulder included, actually come from our cervical spine, from our cervical nerve root. So sometimes patients come to us with shoulder pain and we later find out it's radicular in nature or a referred pain from something upstream. That's why orthopedics is really fun. If you really get down and ask questions and do a good physical examination, a lot of times you can pick up on those things.
And I might add that this person says they're sitting at their desk all day, and there's a prime example where maybe we weren't made to do that, and or ergonomics. Maybe they need to change the level of their chair or their desk, or even stand for a period of the day with a standing desk can help.
Oh yeah.
To work those muscles and so that they're not
No, I would
losing it.
I would absolutely agree. That's critical for treating hand problems, especially we treat a lot of working injuries, and ergonomics I think are crucial. Yeah.
You think of some people that they get their numbness in their ulnar nerve, which comes from getting pinched at the elbow, but they've been resting their elbow on a hard surface all day.
That's right,
at their desk, and so if we can
if they're
loosen
driving
that
a truck and they put pressure on the elbow or keep making their elbow hyperflexed, that's absolutely right.
Absolutely. Well, Dupuytren's contracture is a genetic condition which causes permanent bending of the fingers. It occurs due to the thickening and shortening of fibrous tissue in the hand called palmar fascia. Prairie Doc spoke with orthopedic surgeon Joshua Mike with Orthopedic Institute in T about this condition.
So I'd say there's two kind of variations of patients that present to me. One is with painless nodules or cords in the palm, so just thickenings of kind of the fascia that are under the skin in the hand. Not painful, they just want to know what it is. And then the other presentation is when those cords start to contract and they can make the finger go from being in a straight position to a bent down position over time.
Mike usually says it is usually a clinical diagnosis. They often take x-rays to rule out any underlying arthritis or other issues. He says a common test called the tabletop test can determine if a patient needs any intervention to improve function.
The tabletop is the easiest to remember and easiest for patients to go home with, so that's kind of what I tell patients. If you try to put your hand flat on a table and if that finger just won't go flat and you're having symptoms or limitations, then that's when surgery is typically indicated. There are cutoffs and values for like the MCP joint or kind of your knuckle joint, 30 degrees when a contracture gets above 30 degrees or more than 30 degrees.
Depending on the surgical route the patient takes, recovery time can vary.
Sometimes that cord is really intimately associated with the skin, and so we have to really thin the skin out to get the cord out, and that makes the healing process and the risk of wound healing complications a little bit higher, and so we'll go slower. But in general, it's just getting the skin to heal, and so a period of immobilization and some type of protective dressing and splint to keep the finger out straight so that we don't lose that motion, but also get the soft tissues to rest and heal. And so every patient is different, but usually on the course of weeks as opposed to like months or 9 months like you'd see for an ACL or something. Yeah. A lot of the times people just need reassurance that it's not something that's cancerous or malignant or something to worry about. So a lot of the times that reassurance is something I'm able to offer. But when it does kind of turn into something that limits you, just knowing that there are options to help out with those limitations, and it's not just something that you need to live with because it's non-cancerous and not something that's going to, metastasize elsewhere. So knowing that there are options.
Yeah, Dupuytren's is an interesting one since in the upper Midwest here we have more Germans and Norwegians and Northern Europeans of descent, and it's a little bit more common in that group of people genetically. Now anyone can get it, but sometimes people confuse that with trigger finger. And we do have a couple of questions about trigger finger, and if you can explain the difference for us. This says the caller has problems with trigger finger and a procedure was recommended. She thinks she's getting another finger. I was wondering if there's any other treatment options. So what's trigger finger and what's the difference between that and Dupuytren's?
So firstly, Dupuytren's, with the prominence that you see in the palm, that's not your tendon. That is an overgrowth of that deep tissue in the palm, the fascia, that gives the palm that toughness. Trigger finger is, think of it as a tendonitis, I think, is a good way to think of it. You know, the tendon that curls a finger, or the flexor tendon, travels through a tunnel or a sheath of tissue, and then it can get inflamed and caught up in that sheath, usually in the palm. That's effectively always there. The tissue around the tendon, the pulley, gets thick and then pinches the cord of the tendon. And so then it manifests as a rough motion, or sometimes even just a locking of the finger. And sometimes you can even have pain. It's one of the few problems in hand surgery where you can have referred pain to the joint. So folks will come in and say, you know, either my finger locks up, or I get a lot of pain here, or I press on my palm and it hurts. Well, that's a trigger finger. It's a real misnomer, but that's
Is surgery the only option?
No, you know, it can manifest in a lot of different ways. Sometimes just pain and then it locks up, and then sometimes we just start treatment with cortisone injections, anti-inflammatories, or a splint, and you should see your primary care doc about that. And then of course the final treatment is surgery. And surgery is fairly straightforward. You can be awake when we do it, or sometimes under light sedation, and you go home the same day. It's fairly straightforward recovery. Yeah.
Just to follow up on that, this caller from Mitchell asked about suffering from trigger finger for 3 years and asked about treatment, which we covered. And then they said, what is the expected recovery?
I would say most folks recover, well, let me clarify. It's normal to have a little bit of swelling and discomfort, but usually by the time your stitches are out, which is within 2 weeks at the most, most folks start getting back to normal activity. And even the day of surgery, we want you to move your fingers. We want you to prevent that scar tissue buildup from coming. So when you come back to the office, you should be able to have full motion, get your stitches out, and start getting back to normal activity.
Yeah, I'd echo that. I like it, or whatever. How do you say that when people come with trigger finger? Because I know it's an easy fix, and I can send them to the hand surgeon, and they're going to come back happy.
But you can't take it for granted, because if you have multiple triggers, or in some cases if there are other comorbidities like diabetes, then some folks can have a little bit of a complicated recovery, and so you have to. Everyone is unique in that way.
Right. This caller from Sioux Falls asked about pain after shoulder replacement. When do you think about shoulder replacement, and how's the treatment recovery?
When we think about shoulder replacement, first comes down to x-rays. There are also a few different kinds of shoulder arthritis that can develop. Back to the rotator cuff, there's a chronic kind of arthritis secondary to chronic rotator cuff insufficiency. It leads to a term that we call rotator cuff arthropathy, or just progression of arthritis within the shoulder. There's a unique pattern that we see. There's also a primary glenohumeral joint arthritis that we see, similar to hip and knee arthritis, with an intact rotator cuff. Many times the initial treatment is physical therapy, anti-inflammatories, modification of activities, consideration of injections. When considering joint replacement surgery, I take into account overall health of the patient, activity level, and have an honest conversation with them. How bad is this bothering you? Is your shoulder preventing you from perhaps getting sleep? Is it preventing you from doing things that you like to do? Have we failed all conservative treatment? And if those boxes are checked, then I think it's worth at least having a discussion of shoulder replacement surgery. As far as a painful shoulder replacement, in the setting of, I guess it's important to timeline. How far out from surgery are we? We know that infections can cause pain in replaced joints. We know that loosening of components is becoming more and more rare with modern technology, but it can still happen. X-rays can often provide a lot of information. If there's a concern for an infection being a cause, many times we'll send patients for simple labs, potentially pull fluid from the shoulder joint. And it can be a kind of a in-depth workup, but if it's a truly painful joint having problems, it's probably something worth reaching out to your surgeon about.
And so in the end, their question was how much, how painful is it afterwards? Because I think about, a knee or hip replacement, there's that period of time sometimes afterwards that they're not sure they should have done it, but then they're really happy usually in the end, but yeah.
I think of all of the hip, knee, shoulder replacement surgery, hip by far is the easiest one to get through. Patients just do really well, really fast. And I think knee replacement's probably the hardest. I like to see my patients post-operatively at 2 weeks, and many times they come and ask, what did you do to me? Yeah. But to your point, by 6 weeks, most are doing well. The shoulder is very unique in that I work with very good anesthesiologists. There are really good anesthesiologists at all facilities. And why I mention our anesthesiology team is many of them really do enjoy peripheral nerve blocks. And that's really helpful with the perioperative pain control aspect. Many patients in my practice come and go on the same day as a shoulder replacement surgery. It does depend on medical comorbidities, age, et cetera. But the shoulder replacements a lot of times do get a nerve block. It takes away pain for 2 or 3 days when they would be in the acute phase of pain, where their pain would be the worst. And then most people get by with narcotic pain medication for 7 to 10 days.
I'm glad you brought up the anesthesia part of it too, and how we've got great experts around here, anesthesiologists. That's all they do is pain management and help with the perioperative period and get people to sleep and comfortable for surgery. And we've got a Prairie Doc show dedicated to anesthesia this year that I don't know if we've ever done a show dedicated to that before. So we'll be watching for that later this year. Excellent. This person says, can the doctor talk about how to help with arthritis of the hand? I was diagnosed with it recently. I'm not having any luck with it feeling better. What would you say to them?
That's a tricky one because arthritis of the hand, it could be lots of different types. But if we're talking about sort of good old osteoarthritis, that can affect multiple joints. And they're really there's no real silver bullet that can just make it go away. And that's what we all want. And so you really have to focus treatment joint by joint, especially the more invasive you get, especially as you approach surgery. So your best bet is to start treatment with your primary care doctor. If it is something atypical, work with we can get a rheumatologist involved, and then we approach really just joint by joint. And so that means that if it's at the base of the thumb, we look at surgical options. There are joint replacement options as well for the wrist and some of the smaller joints that we have to discuss on a patient-by-patient basis. There are plenty of options, but you really want it to be really dedicated to your needs, really.
We touched on some of those creams that people use, and the hands are a nice option for those sometimes. Right. And some are over the counter. What are some of the more effective ones that you'd recommend?
Well, they vary highly, but a common one that a lot of patients seem to like is Voltaren gel, for example, and that seems to be a good one. It's tough to use in the winter when you have to wear gloves and be outside, and then your hands get stiff. But that's probably the most common one, I would think.
Yeah. Speaking of, this patient had asked about that. This person said from Facebook, I'm in my 50s, and when it gets cold, my hands hurt. Is this something I need to have looked at besides gloves? What else can I do?
Pain and cold temperature, I think there's certainly an association with the environment, the climate, and arthritis. I don't know why. It's been looked at, whether it's the barometric pressure or whether it's going to rain or snow or when it's cold, and I don't think it's well understood. I think for that, really just look at comfortable type of remedies, heated gloves, different types of warm gloves. But arthritis and cold is a tough one. You will feel some patients describe a lot of stiffness, a lot of pain, and it's somewhat global and non-specific, and really the approach is just try to keep them warm.
Right.
It's just tough. But the good thing about hands is that they're meant to be used and they're meant to be moved. So the worst thing you can do is to stop using them. So keep using them. Get out there and shovel. It's okay.
As with any joint motion, any joint motion is the lotion.
You gotta keep
it
moving. That's
on the medical side of things, I also think about Raynaud's, where the tips of the fingers or the hand or the fingers can turn kind of whitish. Yeah. And that can be an autoimmune condition, and it can be mild, and we don't need to do anything. But sometimes we'll use creams that help with the blood supply, and sometimes even medication pills that can help with the blood supply and help treat that. So obviously wearing gloves and such, keeping it warm and moving it can be helpful, but it's worth a discussion with your doctor about what's going on. Is this an arthritis thing, or is there something else going on?
Raynaud's is, as you know, the vasospastic problem, so the small blood vessels constrict, and then your fingers change colors and get cold, and And that can happen along with arthritis, different types of arthritis. That's right, yeah.
This is an interesting question from a Facebook viewer. With the rise in year-round youth sports, are the doctors seeing more youth injuries? Do you feel like that's been more of a problem?
I think certain sports just render our patients more at risk for injuries. You think of the contact sports, football, basketball. Teenage female soccer players are at risk for certain knee injuries. I'm always in favor of movement and participation and being around your friends playing sports. We did talk about overuse injury in the shoulder, overhead throwers. Is there a concern for overuse with our year-round athletes? Yes, absolutely. I think I would be somebody to make a plug of our more multi-sport athletes. I think involvement in different movements is very important and helpful. If you want to play college basketball, I think there's a certain level of toughness you can gain from doing things like football. To answer the question simply, I think that there is probably a component of kids are more active nowadays, more prone to injuries.
Yeah. I'll even put up a plug for youth to be in sports and music.
Absolutely.
and academics. Yeah. So, it's all important, isn't it?
Absolutely.
This person from Rapid City caller says, why do their fingers and toes cramp?
Oof,
Cramps.
That's a tough one.
That's a tough one. And I'll jump in and save the surgeon that there could be a medical issue too. We'd want to check electrolytes and see how the sodium level is and if we're getting. It might not just be a salt issue, but or maybe we're drinking too much water, or there's so many things that cause cramping, and then sometimes it can be a blood supply issue. And we want to check that. But I don't know when someone comes in complaining of hand cramps, what do you?
Yeah. Well, I would add fun fact: Dupuytren's can affect the feet. You tend to not have contractures. We call it lederhosen, ironically. But in the hands, when you think of cramping, and that's when you look at systemic problems. Okay, is there a blood flow issue? Sometimes if they're younger and they might get dystonia. You have to look for cerebrovascular problems like stroke. I mean, it's really a whole host of things. But carpal tunnel syndrome can sometimes present with nonspecific pain and cramping. So that's number one to look at, amongst the others. Yeah.
Excellent. Going back on Dupuytren's, this caller from Ethan, South Dakota, asked about Dupuytren's contracture and treatments to lessen the effects or physical therapy actions to take. Would wearing a finger splint at night help?
That's a tough one because you're going to have to wear that splint all the time, and then you don't want to lose motion. And again, it's just a thickened cord within the soft tissue, so you may not get the yield out of that treatment that you really want.
We didn't touch on it, but there's surgery to fix it, but there's also that injection.
That's right. So in certain patients, there is a good clear criteria where you can do an enzyme injection, and in fact, it's called Xiaflex or collagenase, and it's something that's produced that we harvest. That's a company makes from bacteria, Clostridium, and then we harvest that enzyme, or the company does, and then we inject it into the cord, and then we do that in the office. And then later on, we manipulate the cord. So it saves you an operation. And
it just melts away, doesn't it?
Well, it doesn't take the tissue out, so you might still have some lumpiness, but it sort of ruptures the cord. And in some practices, different parts of the country, you might see that as a predominant treatment. Here we do that. I think all centers in Sioux Falls actually do that, and I think it's a really good option.
This person said their shoulder popped out of socket and was fixed a month ago. It's still very sore. When will it start feeling better?
I'm assuming anterior shoulder dislocation. That results in, especially in young contact athletes, after a first-time shoulder dislocation, we do recommend surgery. Just a month out, not uncommon. Like we talked about with rotator cuff surgery, the shoulder is going to be stiff. We actually purposely stiffen the shoulder a little bit in the setting of shoulder instability, especially in our contact athletes. All the press is around the labrum. The labrum is a cartilage ring around the socket or the golf tee portion that we touched on earlier. When the shoulder comes out the front, the labrum almost always tears. And so we repair that. There are capsular attachments or the balloon around our shoulder. They're basically capsular thickening that are these ligaments that have labral attachments. So inherently, by repairing the labrum, we often, we'll repair it in an anatomic position. It does end up tightening up the shoulder. My assumption is probably some tightness we know tightness is painful, and so I definitely wouldn't panic at 4 weeks postoperatively.
Excellent. So both of you, this was not your first time on Prairie Doc, so I really appreciate you coming back, and you must like it a little bit or you wouldn't be back, so I really appreciate sharing your wisdom today. In the final, each of you maybe 1 minute, what do you like most about what you do?
Gosh, I really like the technical aspects the most, I have to say that. And then I do like to listen to my patients' stories, because I treat all ages, and they're just fascinating. What they do for their lives and how they use their hands. And then sometimes, remember I grew up in the East Coast, and I've lived here for a long time, more than 10 years, but sometimes I learn something new every single time. And that's probably the most exciting part. Yeah.
And even in a little short answer from you, Tony, too. What do you find most rewarding?
Yeah, I really, really enjoy taking care of young athletes. I was a young athlete once. Injuries in our athletes are devastating. It's sometimes really hard. Not sometimes, it's always hard to deliver news to athletes. You're going to be out of sport for a while with injuries. But been doing this for a year now. It's fun to see kids that I've taken care of last fall back on the sideline. It's super rewarding. They're very motivated individuals. It's very inspiring to me to see these kids. And they put their head down. It's not ideal, but they put their head down, recover, and get back to it. It shows a great deal of toughness, and it absolutely, in my opinion, serves them well for their future. Life's not easy sometimes, but they've been through something tough and recovered. It's cool to see.
Excellent, excellent. Well, our winner tonight is Shelley. A book will be sent to you shortly. We'll be back after this.
Hi, my name is Preston Holm. I serve on the Healing Words Foundation Board, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Have you subscribed to the Prairie Doc radio podcast yet? Join host Laura Ellsworth each week as she engages with health professionals to explore and answer your questions on vital medical topics that matter to you. Don't miss out. Search for Prairie Doc on Apple Podcasts, Spotify, SoundCloud, or your favorite podcast platform today.
As we finish up this evening's discussion, I want to thank Dr. Manon-Matos and Dr. Fiegen for sharing their expertise with our viewers. And a thank you to all of our viewers for tuning in tonight. We appreciate your continued viewership and support of our mission of providing science-based health education to everyone. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question tonight, or it didn't align with our topic, send your question to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on South Dakota Public Radio and on podcasts. And be sure to download and subscribe to the podcast version of this show and Prairie Doc Radio wherever podcasts can be found. Thank you for joining us for another On Call with the Prairie Doc. Until next time, as our founder, Dr. Holm would say, stay healthy out there, people.
Perimenopause is the transitional phase leading up to menopause, characterized by fluctuating hormone levels. Understanding perimenopause, next time on Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,